Hello. Hello. Check. Check test. Hello. 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 Check. Check test. Hello.
Good afternoon, everyone.
Hello.
Welcome back to today's afternoon session of hands-on cadaveric workshop on head and neck surgery. I would like to kindly request Dr. Kannan S., consultant at Apollo Cancer Center, Chennai, for the next session, a step-by-step demonstration of neck dissection. Requesting Professor Gopalakrishnan to kindly chair this session.
Good afternoon, everybody. So this session, I think Dr. Kannan will present, will be demonstrating the step-by-step involved in the dissection of head and neck. See, head and neck, this one, neck dissection is an integral part of one who is involved in head and neck surgery. And roughly about, say, 250 to 300 lymph nodes there in head and neck, grouped in different groups. And they get removed in various types of neck dissection. I think Dr. Kannan will be demonstrating the various type of neck dissection step by step. Dr. Kannan, of course, is a consultant in Apollo.
Yes.
He had his MBBS in Chengalpattu Medical College way back 2003, and he did MSc ENT with us in JIPMA in 2007. After that, he got his fellowship in surgical oncology in Tata Memorial Hospital, Bombay. And after that, more than 2 decades, he's been working in Apollo Hospital. Over to Kannan, please.
Thank you, sir. Thanks to the Mahatma Gandhi team for having me here. So as sir told, neck is the most integral part in management of cancers. Presence of a neck node will decrease the survival by 50%. Presence of an extranodal extension will even decrease it further by 50%. So addressing the neck is quite critical. So neck is addressed in 2 ways. One, when there is no neck node metastasis, N0 neck, we address the neck. That is management of N0 neck. When there is a positive node, we address the neck. So whenever there is N0 neck, we will remove the possible basins in which the neck can spread. So as you all know, neck contains various level 1 to 5. So we will discuss about these levels as we open up and do. So whenever you have a oral cavity cancer, you have to remove level 1, 2, 3, 4. And if you have a laryngeal tumor, you have to remove level 2, 3, 4, 5. This is the basic of neck dissection. So now, before entering into neck dissection, we need to know about the incisions. Of the incisions, 2 things is very important. One, lines of Langerhans. The lines of Langerhans is usually parallel to the neck skin crease. So this is the prominent skin crease here in the neck. Second, vascularity of the skin flap. Skin flap derives vascularity from periphery. So these are the directions. So the center area is the one which is very least vascular. Remember these 2 things when you plan for a neck incision. Usually nowadays when we do a supraomohyoid neck dissection, which is the most commonest, we select the prominent crease. This is the angle of the mandible. This is the mentum. This is mastoid process. We select the prominent skin crease at the level of the hyoid and at least 2 finger breadth below the mandible. So this will be our normal skin crease incision with which we will do the supraomohyoid neck dissection. But the most commonest incision used is Schobinger's incision. It starts from the mentum, comes up to the hyoid, and then you come into the skin crease, and then you take this incision up to the mastoid process. So this is the upper part of the upper part of the Schobinger's incision. Below, in the lower end of the neck, you see this is the clavicle, this is the acromion. You divide it into 2/3, 1/3. And then you drop a vertical point here, and then you connect it. So this is the lower limb of the Schobinger's incision. In this, there are a few points to be noted. This is the least vascular area, and this tip can get necrosed, this side and this side. So whenever you make this incision, make this absolutely vertical. Second, where will you put this, drop this vertical point, here or here? So when, if at all this tip gets necrosed, you don't want the carotid to get exposed. So you identify the carotid, so place it as posteriorly as possible. So carotid is somewhere here. That's why we have placed it posterior. Third, why didn't we make it a straight incision? Once it heals, the straight incision, it heals with a scar. So it is called as criles. It produces a very bad scar. To break the scar, we have made it lazy S incision. So these are all the points about Schobinger's incision. Today, we will do the surgery with Schobinger's incision so that the exposure is better. For all beginners, even though the scar is bad, leaving behind a neck node is the worst. You leave behind a neck node, you'll have a dead patient. So don't worry about scar in an oncological surgeries. Till you get your training, get your maximum exposure. Maximum exposure you'll get with Schobinger's. The second best incision. If you have to do the neck dissection, you take this upper limb, lower limb, you can take it as a as 2 finger breadth above the clavicle. So this will be your lower skin crease incision. This is called as a McPhee's incision. That's okay. Okay. This is called as the McPhee's incision. Okay. These are all the incisions which we used for neck dissection, particularly for oral cancer patients or for patients with unknown neck nodes with unknown primary. If you have a laryngeal cancer patients, the patient might need laryngectomy at a later stage. In such patients, we take a inverted hockey stick incision. So this will come here and then you connect it in the middle. So if at all you need a later you have to do a laryngectomy, you can convert it this side and become a Gluck-Sorensen incision. So hockey stick is nothing but a half of the Gluck-Sorensen incision. So this is what it is. So today we will do a Kryle's incision, Schobinger's incision, neck dissection. First, we will go through supraomohyoid neck dissection, and then we will convert it into a modified radical neck dissection. So 15 blade. So as Dr. Sri Prakash told, you cut the skin, superficial fascia, platysma. So we have cut the skin now. In the middle, you will not have the platysma. Here you look for the platysma. Skin, subcutaneous tissue. Here is the platysma. This patient has a very thin platysma. Tooth forceps. So this is the thin platysma. We are cutting the platysma now. This is your external jugular vein. This is your greater auricular nerve. Preserve the greater auricular nerve as of, so it will help you in identifying the spinal accessory nerve in the level 5 area. So this is your platysma. Here you have cut the skin, subcutaneous tissue. Now, as we did before, we will use a Alice forceps. We would use it in the soft tissue, particularly in the platysmal area. One more. So hold it vertically on top. Gentle. Hold it, doctor. Great. So now when you raise the flap, you have to see on the upper end of the flap. The bare platysma should be there. All the fibrofatty tissue should be on the patient. So we are raising the superior flap. We don't cut the external jugular vein as much as possible. Try to preserve the greater auricular nerve. This is the greater auricular nerve. One more hallus. Great. So drop all the fibrofatty tissue down. You see the bare platysma on top. You rise it till the lower border of the mandible. Now you see the faint view of the digastric. Okay. First, we start with level 1A. So to do the level 1A, we will rise a little bit on this side. Level 1A is in between the two anterior bellies of digastric. This is the platysma on the other side. Gentle. Beautiful. So this is your digastric on the other side. So can you all see this is digastric on the left, digastric on the right. Digastric on the left, digastric on the right. This is level 1A. So the base of level 1A is formed by the mylohyoid muscle. So now we'll start off with level 1A. So this is fibrofatty tissue in the level 1A, and level 1A nodes will remove along with it. We usually do it with a cautery. So now you see the mylohyoid muscle below. The only other important structure which comes in level 1A is at the inferior end, you will get the terminal branches of anterior jugular vein. Okay. So can you see faintly the anterior jugular vein here? So clear the level 1A. So now we have done with level 1A. Next step is level 1B. Level 1B, we have to identify the facial artery and facial vein on the top. If possible, we'll try to get the marginal mandibular nerve. There are few basic things in identifying the marginal mandibular nerve. So there is a fascia just below the platysma, that is investing layer of deep fascia. And there is one more fascia below that, that's the fascia covering the submandibular gland. The marginal mandibular nerve is present in between these two fascias. Second point, you have a perifacial node here. So your marginal mandibular nerve is on top of the perifacial node. So this is the marginal mandibular nerve. So your perifacial node will be on top of the marginal mandibular nerve. Third point, this is what is called as Haynes-Martin's technique. What he did was he identified the facial artery below, facial vein below, ligated it, and he preserved the marginal mandibular nerve by this technique. The problem with this technique is the perifacial node is present above the facial artery. In this technique, you will not remove the perifacial node, which is not good in an oncological surgery. As a beginner, if you have a positive node in level 1B, don't bother about marginal mandibular nerve. Marginal mandibular nerve paresis is acceptable, but leaving a neck node in level 1A or 1B is not acceptable. So next step, we have seen the marginal mandibular. Next step, we would identify the facial artery and facial vein. Just trace the marginal mandibular. Below the marginal mandibular now, you'll have the facial artery and facial vein. Small mosquitoes are very useful in this area to dissect. So now more and more as we are doing the microvascular reconstruction, I hope you all can see the marginal mandibular now. So I can Proceed to the next step. Sometimes you can have two branches like this. Screen energy. Focus it here. Top layer, bottom layer, marginal mandibular nerve. There is a glare. It's very difficult to get a pretty good marginal mandibular nerve like this. Yeah. This is the fascia which I was talking about, glandular fascia, submandibular gland fascia. Once you cut this fascia, below you will see the facial artery and facial vein. Facial artery is usually anterior, vein is posterior. And whenever you do a microvascular reconstruction, preserving these vessels is quite critical. Okay. Your marginal mandibular nerves. This is the gland, yeah. So we will dissect and push the nerve up. As the nerve goes up, then we will start dissecting in this area. This is normally the location of your perifacial node. Below the perifacial node, you will have the facial artery. This is your facial artery. When in neck dissection, if you are not preserving the facial artery, you will see facial artery at two places. One on the lower border of the mandible, other when you reflect the submandibular gland. This is the facial artery. And as I told you, marginal mandibular nerve on top, one branch, two branch. This is one branch, two branch. Not seen, no? Not seen. Nerve is seen. Okay. So for the want of time, we'll proceed. I'm sacrificing the facial artery here. Once you have done with the facial artery, then get your facial vein. This is a facial vein. You sacrifice the cervical branch. This is a cervical branch. We sacrifice the cervical branch. Then ligate the facial veins. If you are going to do a microvascular surgery, you put a liga clips and preserve these veins. Okay. This patient being if this would have been a patient, you would have had a perifacial node here. Now we sacrifice the facial vein. So now we have done with facial artery, facial vein. The next step is to dissect off below and identify the lower border of the mandible. So as we have done with the marginal mandibular nerve, we have done with the facial artery, facial vein. Next step is identifying the lower border of the mandible. This is the screen, can you see? And this is the lower border of the mandible. And this was the node which our doctor was pointing here. Okay, so now the next step is identify the mylohyoid. Yeah, can I get a good scissors, please? So this is our anterior belly. So curved. This is our anterior belly. Once you cut the anterior belly, then you will see the mylohyoid muscle below. Now you will have a perforator for mylohyoid. So this blood vessel will usually bleed in this area. This is the blood vessel which we use it for submental flap. So anticipate some bleeding. Usually this area is done with cautery. Being a cadaver, we can go without cautery. So this is, you're seeing the mylohyoid getting separated. Now, once you separate the mylohyoid, then you get down, identify the digastric tendon. Huh? No, the node was, this is the node. Huh? This is the submandibular gland, which is dropped down a little. So now we have completed the level 1A. We'll connect the level 1A with level 1B. Okay, we'll go with the knife. Yeah. Yeah. So this is your anterior belly of digastric becoming tendon. See, sir? Now you have to identify the border of the mylohyoid, and my assistant will retract the mylohyoid. Once he retracts the mylohyoid, then we will see the structures below the mylohyoid. So this is the vessel which I was talking to you on. This vessel is the one which we use it for submental artery, submental flap. And normally in neck dissection, we sacrifice it. Once you do this, you identify the border of the mylohyoid. This is the border of the mylohyoid. Take a retractor, doctor. Okay. This is better. Good. So once gently you retract the mylohyoid, here you will see the hypoglossal nerve. This is your hypoglossal nerve, and we'll also dissect in this area. Take your gentle. Okay. Here below you have the hypoglossal nerve. You have your duct here, submandibular gland duct. And above the submandibular gland duct, here you're seeing the lingual nerve. Hope you all can see the lingual nerve. These are the lingual nerve fibers. No, I want a light inside. Sorry. Can I have a headlight, please? So this is the lingual nerve here. Hypoglossal nerve below. Lingual nerve above. In between, you have your submandibular gland duct. These three structures seeing is quite important. We'll spend some time, show it, and then move on. Where is this button? Yeah, switch it on. Yes, sir. Good. இல்ல வேணாம் sir. Okay, can we go now? Can you see on the screen? This is the lingual. So this is the lingual. This is the hypoglossal below, lingual. And usually you get a small communication between the lingual. Huh? Yeah. Yeah. Do that. The light focus பண்ணுங்க பார்க்கலாம். Focus these lights. Your head. Yeah, beautiful. Yeah. Can you see this? This is the lingual nerve, and this is the postganglionic fibers from the lingual nerve, which is coming here. So you have to, and this is the submandibular duct. I'm dissecting the lingual nerve of the submandibular duct, and hypoglossal nerve is below. So now I take the hypoglossal submandibular duct, and also you have to, this is the ganglionic secretomotor fibers from the lingual nerve to the submandibular gland. This here you have the sublingual ganglion. Then we take the sublingual ganglion also. Once we do this, then we are done with the submylohyoid dissection. So you see the lingual nerve, you see the lingual nerve, you see the submandibular duct. Below that, you see the hypoglossal nerve. So once we done this, this structure is coming into better view. This is your tendon of digastric. So once you see the tendon of digastric becoming the tendon of digastric becoming the posterior belly of digastric, in that area, you will usually get the facial artery, second branch, the entry point of the facial artery. So identifying the facial artery is quite critical, because whenever you do a microvascular surgery, this preserving the facial artery becomes very important. Hope you can see the marginal mandibular nerve here, 2 branches, 1, 2. Your head there. Marginal mandibular nerve, 2 branches, first branch below and upper branch 1 more. So once we do this, here you see the facial artery again. This is the facial artery. If at all, if you are going to do a microvascular surgery, we would try to preserve the facial artery. You can dissect it off. And this is the area where we had cut it from top. You have to clip, there will be 4 branches from the facial artery to the submandibular gland. You have to identify, clip those vessels, and then you can preserve the facial artery. So this is the facial artery which is preserved for your neck dissection. So this is your clearance of your level 1A and level 1B. And now we have identified the digastric. Okay. So I told you this is the tendon of digastric becoming posterior belly. Other important, interesting finding here is, you see one more muscle here. This is stylohyoid muscle. Stylohyoid muscle will have it divides into 2 parts, and it encircles the tendon of digastric, and it inserts into the hyoid bone. So here you see that muscle as well, encircling the tendon of digastric. Okay. Now we have done this. Next, we would open up the we would open up the sternocleidomastoid to clear 2, 3, 4. Yeah. Up to this step, we would do it with the same single incision. Once we finish the part of showing the structures of neck dissection, then we will get down for Then we will make the Cryles incision. Great. So now we see the anterior border of sternocleidomastoid. Identify the anterior border of sternocleidomastoid. Cut it. Cut it. Now you use a Babcock to hold the anterior border of sternocleidomastoid. Hold it gently. You dissect it off. Now you see the anterior external jugular vein entering into the parotid gland. This is one important landmark. This is the external jugular vein entering into the parotid gland. Almost in the parallel plane to this, you will get this spinal accessory nerve. So this is the same parallel plane. Underneath, you'll get the spinal accessory nerve. As we were discussing, whenever you have to look for a structure, get the exposure better, then go for the structure. So now we have done this. I will sacrifice the external jugular. Then we'll get N. That's okay. So now, next step is exposing the posterior belly of digastric better. Never go and hunt for the marginal mandibular spinal accessory nerve before you expose the posterior belly of digastric well. Expose the posterior belly of digastric very well. Only one important structure which goes above the posterior belly of digastric, that is common facial vein. All other important structures are below the posterior belly of digastric. So you can be literally really bold above the posterior belly of digastric. Here we have dissecting above the posterior belly of digastric. And now we will use a retractor and expose the sternocleidomastoid further. Hold this, doctor. So this is your sternocleidomastoid. You're exposing it well. Yeah, retract. Good. Now we have exposed this area. We will retract the hold this. Yeah. You retract the anterior border of the sternocleidomastoid. Here you're starting to see the internal jugular vein. Okay. Internal jugular vein better delineated. Then you enter into our triangle of interest. This is the triangle of interest. You come up. In this triangle of interest, you will start seeing the spinal accessory nerve. Yeah. This is your spinal accessory nerve. This is a very good cadaver. So usually whenever you are doing a live surgery, you will see a vein which is usually accompanies the spinal accessory nerve. And you can also see that vein very well here. So this is the vein. This is the vein, and below you have the spinal accessory nerve. This is the vein which accompanies the spinal accessory. Here you can see the spinal accessory nerve. Now the spinal accessory nerve is dissected off. So the technique in identifying spinal accessory nerve, always expose the external jugular. I told you this is how your external jugular was. It is always in a parallel plane below. So expose the external jugular, open this plane up, identify the posterior belly of digastric. If it would have been like this, you would not have got. So identify the posterior belly of digastric, dissect it up to the mastoid process, go down, identify the internal jugular vein, expose it further, then open up. So whenever you get a bleeder, don't rush to clamp it. You can see the vein here. So don't rush to clamp the vessel because it is the bleeder which is just above the spinal accessory nerve. The entire vein is seen very well. So then you can sacrifice it. So this is about our 1A, 1B and identification of spinal accessory nerve. So now next we can open up our Kreil's incision and demonstrate the level 5 area. Yeah, hold it that way. Great. Knife. Yeah. So this is very important. This tip, this should be at 90 degrees so that your skin flap necrosis is very less. This incision should be at 90 degrees. Once you make it, hold it. Yeah. Then you curve it posteriorly and then make a lazy S incision. Hold it. So then you cut the platysma. Once you cut the platysma, you start raising the anterior flap. Since we have done a thyroidectomy, this will get into that incision as well. So as we did before, we'll use our Alice forceps. Hold it. Take one more. So the entire head and neck surgery happens in planes. It's all about traction and counter traction. So this is going anterior to the sternocleidomastoid. Yeah, take all these, no? Yeah, yeah. Take it out. Hold it. So similarly, go in the subplatysmal plane, leave all the fibrofatty tissue down. This anterior flap is quite easy because you have a sternocleidomastoid as your landmark above which you can keep dissecting. So we have taken it down up to the clavicle. Okay. The next step is raising the posterior flap. Hold it like this. Leave that, leave that. Hold this head like this. Right. Once you raise the posterior flap, your guide would be external jugular vein. You stay above the external jugular vein, anterior greater auricular nerve. Preserve the greater auricular nerve. And you see the fat of the skin. This is the fat of the subcutaneous skin. So be just in that layer. Because posteriorly, as discussed before, your platysma is dehiscent. So when you raise this flap, you rise in the fat plane. This granular fat is your skin fat. You go in the fat up, fat down plane, your chance of injuring the nerve is lesser. Since you have taken a posteriorly based incision, you have to go up to the trapezius, and the distance you need to travel is pretty less. Okay. Okay. So now next step is you identify the greater auricular nerve. Take down the greater auricular nerve up to the posterior border of your sternocleidomastoid. So that would correspond to your Erb's point. So this is your Erb's point where your confluence of nerves is there. And you will get your spinal accessory nerve roughly a centimeter on top of it. Yeah. So this is your Erb's point. Probably this is your spinal accessory. Now we have to dissect it further to confirm. Two nerves which will confuse you here. It is a lesser occipital nerve which curves up. Spinal accessory nerve comes down. So whatever nerve you get, you trace it. So the most important nerve to be preserved when you raise the posterior flap is your spinal accessory nerve. You dissect the spinal accessory nerve. When you dissect the spinal accessory nerve, your assistant holds a retractor and keeps the nerve taut gently. Once he keeps the nerve, hold this here. Hold it with your hand. Once you keep the nerve taut, you can dissect it below. You have to dissect it till you see it entering into the entering below into the trapezius. So this is your spinal accessory nerve getting down below your trapezius. Even spinal accessory nerve can have branches, but preserving the main spinal nerve is important. The rest all the branches can be sacrificed. And one more part of the spinal which you need to preserve is your proprioceptive fibers. Okay, so now we have done with this. So next, by preserving the spinal accessory nerve, we have to sacrifice, you have to remove the sternocleidomastoid muscle. That's the part of modified radical neck dissection. You go through you go just above the nerve, open that area, then cut it. So here something important. So once you dissect the nerve, always keep in mind it also gives a branch to sternocleidomastoid. You have to identify it and then cut it. This is what we have identified it at level 2B. Now we are dissecting it at from level 5. So this is your spinal accessory nerve from level 5 to level 2. Now you can see a branch which is getting down into the sternocleidomastoid. This is the sternocleidomastoid branch. You need to sacrifice the sternocleidomastoid branch and preserve the main branch. Okay. So once you have done with this, then you get down to, you get on top to cut the upper part of the sternocleidomastoid. You can use the retractors. Come, hold it here. One more retractor, hold it here. Great. Now that you have identified the IJV, you have identified the spinal accessory nerve, you can boldly cut in this area. We normally cut it with you cut it from the mastoid process. There will be a little bit of oozing here. Great. Take the spinal accessory nerve up to the point where it is entering into the this thing. This is the spinal accessory nerve in toto. We have cut the upper end of the sternocleidomastoid. This is the base of level 2B. Now we are doing level 2B clearance. Now delineate your internal jugular vein well. This is your internal jugular vein. We can even open up the fascia above it. This is our internal jugular vein. So we dissect all the nodes and fibrofatty structures around the internal jugular vein. Now we are clearing level 2A, 2B and level 5A. Once you do this, you would drop it below the spinal accessory nerve. This is your spinal accessory nerve. Let's dissect it well from below. You can see a branch of spinal accessory nerve which is coming from below. This is the one. This is the proprioceptive branch. Try to preserve the proprioceptive branch if possible, but it's not compulsory if you're preserving the main branch. If during your beginning stage, if you inadvertently cut your spinal accessory nerve in the level 2, preserve it from the proprioception so that the shoulder drooping becomes very less. So identifying the proprioceptive branch is quite important. So this is your proprioceptive branch of your spinal. Now we have identified and preserved the proprioceptive branch and the main branch. So we are removing all the fibrofatty structures from this area. You're doing good. Great. Okay. So this is done. So now the next step is we will go down, cut the lower end of our sternocleidomastoid, identify the omohyoid muscle. Hold this. So this is your omohyoid muscle. So you dissect the sternocleidomastoid anteriorly. You dissect the sternocleidomastoid posteriorly. Preserve the internal jugular vein and take the lower cut. So this is your clavicular sternal head of sternocleidomastoid. This is your clavicular head of sternocleidomastoid. Once you remove this, then you identify your omohyoid. This is a omohyoid muscle. Similar to the digastric on top, no important structure comes above the omohyoid, except your external jugular. So if you're preserving external jugular for microvascular reconstruction, you dissect it off first, put it above the omohyoid, then cut the omohyoid. So here you see the external jugular. So this carries importance only when you do a microvascular reconstruction. So if at all we are doing a microvascular reconstruction, you take efforts, time, and then preserve it. So you identify the external jugular. This is your external jugular. Sometimes transverse cervical vein empties into external jugular, clamp it and then cut it. Once you preserve the external jugular like this, then you can see the omohyoid below. Tendon of omohyoid. It crosses over the tendon of omohyoid. Then you can take the omohyoid tendon. So your external jugular is preserved. You are taking the omohyoid tendon. So identify the omohyoid tendon, hug it, and you start releasing on top of it. So this will open up your internal jugular vein and your carotid space. You can just below you'll have your carotid sheath. Once you do this, you will see your internal jugular vein very well and your carotids. So now we have to start dissecting the level 4. The important structure which we need to identify in level 4 is your transverse cervical vessels. This is your transverse cervical artery and vein. Okay. So this transverse cervical artery and vein, the point where the transverse cervical artery emerges, this is the area, usually you'll have a jugular duct on the right side and chyle duct on the left side. So if at all you have to look for the chyle, identify the border of your identify the border of the internal jugular vein, dissect it, roughly 2 finger breadth above. Up to this area, you can have your chyle duct. So, but usually on the right side, you don't have chyle ducts. So you can cut that off. So once you cut it, below you see your transverse cervical. The transverse cervical artery forms our lower limit of our neck dissection. The other structure which you need to identify here is phrenic nerve. This is your phrenic nerve down. So identify and preserve the phrenic nerve. This is usually a blackish node we call it a smoker's node or pollution node. So this node is usually drains the lung structures. And if it is positive only in lung malignancies, it's not relevant for head and neck cancer, but this forms the lower limit of our neck dissection. So lower limit laterally would be your transverse cervical. Inferiorly, the node will be also form our neck dissectional border. Okay, so now here you will have a branch, ascending branch of transverse cervical artery. You need to clip the ascending branch of transverse cervical. This is ascending branch of transverse cervical artery. Okay, you need to clip it and then go for the next step. And there will be multiple branches at times. And whenever you do a neck dissection, this is your pretracheal fascia. Try to not breach the pretracheal fascia. Okay, great. So now we have identified the spinal accessory nerve and we had seen it entering into the trapezius here. Hold this down. You can come this side. Great. You leave this, keep this nerve taut here, just with your finger. Great. So now we have preserved the spinal accessory nerve. We have to take all the nodal structures. This will form 5B. So spinal accessory is preserved. Usually you have a vein here, which needs to be taken care of. So here you have your transverse cervical, trace your transverse cervical behind, identify your spinal accessory nerve, take all the structures in between in this area. These are all the ascending branches of transverse cervical. You have to clip it and cut it. This would be supraclavicular fat, whichever is below the spine, which below the transverse cervical, you need not remove it. Whichever is in between the transverse cervical and spinal, that needs to come out. Straight artery. You take Alice or straight artery and gently hold it. Gentle, like this. So you dissect your transverse cervical, take all the nodes between transverse cervical, and this is the plane which you have to see. This is the pretracheal fascia and the plane. If your assistant gives good traction, you'll start seeing it, dissecting it out. You can even flip it with your finger. So disconnect the spinal accessory nerve from the specimen. So now we are preserving the pretracheal fascia and removing the rest of the structures. Now you will come up to your internal jugular vein. Great, hold it. Beautiful. Gentle, doctor. Hold it. Here we have seen our, hold it down. So here we have seen our internal jugular vein. We have seen our phrenic nerve here. This is a phrenic nerve. Here in between these two, you'll have your brachial plexus. Now stay superficial. From here, you'll be sacrificing the cutaneous branches and you will preserve the brachial plexus. Brachial plexus is here between the vessels. So cervical rootlets you have to cut. and then you will end up in your internal jugular vein. Hold it, leave it, hold it like this. So now we have ended up in the internal jugular vein. So gently shave your structures of the internal jugular vein. So this would complete your level 5 neck dissection. So you're dissecting it off the internal jugular vein. So now we have cleared our level 5. Before proceeding further, we'll identify our structures. This is, hope you're all seeing this. This is your spinal accessory nerve going below the digastric, above the internal jugular vein. This is your proprioceptive branch of the spinal accessory nerve, proprioceptive branch, spinal accessory nerve. And your spinal accessory nerve enters below the trapezius. And it is usually like this. If you have if you are not able to identify the spinal accessory here, identify the trapezius below, and 2 finger breadth above, you will see the nerve entering below the nerve entering below the trapezius. So this is another landmark. 2 finger breadth, you'll see the nerve going into the spinal accessory one. Third, you are seeing the transverse cervical artery here. You're seeing the phrenic nerve here. This is the brachial plexus. Here we have cut the rootlets. 1, 2, 3. 1, 2, 3. All the three cervical rootlets we cut. Now, once we do this, we will take down all these structures anteriorly. Okay. So now for the want of anatomy, we will do it this way. Okay. So now we have cleared level 1A, 1B, level 5, level 2, 3, 4. Now the area which is remaining is the carotid triangle. This carotid triangle is quite important because it will have the jugulodigastric node there, and any nodal recurrence which occurs in the carotid triangle would invariably be on the carotid, and it will infiltrate it and it becomes non-salvageable. So clearing carotid triangle is quite important. So for the want of it, I remove these specimens out. We will concentrate on carotid triangle alone now. So at one point, you'll see the common facial coming out of the. So identify the IJV. Okay, great. This is your superior thyroid area. You can see the superior thyroid vessels. Okay. And we would try and dissect and find out where our common facial vein, if at all it is there. Yeah, this is a common facial vein. Common facial vein, I told you it is the only vein which transfers over the, which goes over the digastric. And this is a common facial vein. Okay, this is an important anatomy. When you have your common facial vein, once you dissect the common facial vein off, between the common facial vein and your internal jugular vein, you will have your carotids. This is your carotid. Can you see this? Between your common facial and your internal jugular vein, you will have your carotid. So you have to bare this area. You can see it much better now once we remove things off. Yeah, put a retractor here. So this is the most important carotid triangle node, which once you don't remove it now, it becomes non-salvageable. So this is your carotid triangle node. This is your common facial. The main branch we have cut it, which transfers over the branch of the common facial. This is your carotid artery. This is the internal jugular vein. Now, rest of the structures you can remove, not a problem. There are usually 3 feeders to sternocleidomastoid. So one from the occipital artery on top, from the superior thyroid artery here, transverse cervical artery below. So these are all the branches which usually goes to the sternocleidomastoid. You need to sacrifice all these in case if you are removing your sternocleidomastoid. Once you do this, you can take this off. Here, for the want of anatomy, this is your carotid artery. And this is one important structure. In case if you have taken the common facial, you will come across this structure. For demonstration, I'll take off the common facial now. Once you take off the common facial, 1 second, doc. What is this nerve here? This is like digastric. This is another guide or friend of us. You can see this one getting down below here. This is your ansa hypoglossal. This goes up and it enters into the hypoglossal nerve. The more than anything, this would act as a guide. This is on top of the carotid sheath. So as long as you are on top of the ansa hypoglossal, you will not damage the carotid artery below. So always try to identify the ansa hypoglossal and preserve it. Here you can see the ansa hypoglossal joining with the hypoglossal nerve. This is the hypoglossal nerve here. Ansa hypoglossal joining there. And these are all the vena committents. Whenever you're doing a neck dissection for the first time, and if you're doing a radical neck dissection, we would ligate the internal jugular vein here. We would ligate the internal jugular vein here. And when you're dissecting in this area, you'll get a tremendous bleeding. So always during radical neck dissection, spend some time, identify the vena committents and clip them. They can cause nasty bleeding. It's easy to control, but you should be careful about your hypoglossal nerve when you're controlling it. So this is our hypoglossal nerve. So we would normally we would tie it or clip it. We've seen the hypoglossal nerve. This vena committents, you have to tie it well. This structure is important. So when you do a tongue surgery, you have to identify most of the times you have to identify the lingual artery and clip it. So you identify the hypoglossal, push the hypoglossal down, just below the digastric, you will get the lingual artery knuckle. This is our lingual artery knuckle. Whenever we do a tongue wide excision, we usually tend to ligate this area, ligate this lingual artery so that it doesn't bleed in the post-operative period. So this is the lingual artery. What is the anatomy? How do we get to it? Identify your vena committents, cut and clip the vein on top, identify the hypoglossal, dissect between the hypoglossal nerve and your digastric tendon. You will see this knuckle here. Okay. On top of it, you'll have your facial artery. This is your facial artery. So now, last point. So you've seen the facial artery here. whatever structure which enters into the submandibular gland from here is facial artery. And whatever structure which enters into the parotid gland, hold it. This is external carotid artery. Morning we saw parotidectomy. When you do a deep lobe parotidectomy dissection, you have to identify this external carotid above the digastric and keep it, so that in case you need to sacrifice the deep lobe, then you can do. So this is your external carotid. This is your facial. So whatever artery which enters into submandibular is facial, which goes below the parotid is external carotid. So thank you, and revise the anatomy before we wind off. You have your marginal mandibular nerve here. Below the marginal mandibular nerve, you'll have your facial artery anteriorly and your facial vein posteriorly. In live patients, this is your facial vein. In live patients, you'll have a node there. You have to remove that node. This is level 1A between two anterior belly of digastric. You have your mylohyoid here. Second 1B between the anterior belly of digastric and posterior belly of digastric. You retract the mylohyoid. Gently, you will see the hypoglossal nerve here. This is a hypoglossal nerve. As we dissect further, you can see it better. This is a hypoglossal nerve. Okay. And here you have your lingual nerve. This lingual nerve, you have your sublingual gland, which we are resected it. This gives proprioceptive fibers to the submandibular gland. And this is your facial artery. This usually, it's at the place where your digastric tendon is engulfed by your stylohyoid muscle, or where the digastric muscle becomes, the tendon becomes muscle, you have to look for your facial artery. This is your facial artery. And whenever you have to look for your spinal accessory nerve, identify your posterior belly of digastric, dissect it till the mastoid, then you identify your spinal accessory nerve here. So this is the spinal accessory nerve. Spinal accessory nerve, yes, your proprioceptive fibers. These are all your cutaneous fibers. And below this is your pretracheal fascia. Whenever you do a neck dissection, try not to breach this fascia. So most critical structures are below this pretracheal fascia. Your phrenic, your brachial plexus, everything. So all the structures, all the nerves which is above the pretracheal fascia or cutaneous nerves, you can sacrifice them. So I'm happy to take any questions. Can we start the neck from below? Yeah, we can, sir. Yeah, yes, sir.
Now, coming to this one, no, post-RT cases or some other surgery when the carotid gets exposed. There are some ways to prevent that carotid blast. No?
Yeah. So you can use a levator flap whenever you have a carotid exposed, and whenever there is communication with the oral cavity or the pharynx, the carotid gets bathed with the salivary secretions, increases the chance for carotid blowout. In such cases, you identify the levator scapulae muscle here. You cut the levator scapulae muscle from this, from its attachment on the from the scapula, and then flip it and close it here. This is one way of preventing the exposure of the carotid. Second, you can use a pectoralis major muscle to cover the carotid off. So never leave the carotid artery exposed to saliva. That is for carotid blowout. So if you have a sternocleidomastoid, if you're doing a total laryngectomy, then you can cover stitch the sternocleidomastoid in front of the carotid. So these are all the various ways in which you can protect the carotid. So PMMC muscle, levator scapulae, sternocleidomastoid.
The other thing that's Kannan, when you manipulate the carotid artery, invariably you stimulate the carotid sinus also.
Yes, sir.
Just show them the area of the carotid sinus and how to prevent the excessive
So,
stimulation of the carotid body.
Mosquito. So carotid sinus is usually present at the level of the carotid bulb. So this is your carotid, common carotid. So common carotid becomes internal carotid artery and external carotid artery. This is your external carotid artery. External carotid arteries will have branches. Okay. So these are the branches of external carotid artery. So this is your carotid bulb. If you stimulate in this area, then you will have bradycardia. So carotid sinus is present somewhere in the jugular bulb. So and similarly, whenever you ligate the external carotid, never ligate the external carotid, bang close to this. Always leave the superior thyroid and ligate on top of it. Because if there will be retrograde thrombus, which will enter into the internal carotid artery and it will cause stroke. So if at all you're ligating the external carotid artery for a patient who is badly bleeding, you want to secure the stop the bleeding, you are not able to do even after ligating your lingual artery, even after ligating your facial artery, then you identify the common carotid, identify the common carotid, identify the bifurcation, definitely identify the superior thyroid artery, then only ligate it here. So you have to ligate it here between your lingual and this is lingual, this is superior thyroid. You have to ligate in between these two. So this you stimulating in this area, as sir told, will cause brady. So undue no pressure.
Thank you, Dr. Kannan. If anybody has got any questions, can you just enlighten them? What are the groups of lymph nodes removed in selective block?
Selective neck dissection, yeah. So selective neck dissection depends on the primary. Most commonest oral cavity primary. Oral cavity primary for buccal mucosa, first echelon will be 1B. So you must remove the perifacial node. Don't worry about marginal in buccal mucosa cancers. So in tongue cancers, level jugulodigastric node or level 2 node will be the first echelon. So in any oral cavity, remove 1A, 1B, level 2, 3, 4. Whenever you have your lesion in the larynx, you remove 2, 3, 4, if needed, level 5. Whenever you have your lesion in the thyroid, tumor in the thyroid, you will clear the central compartment there. And if it comes to the lateral neck, first echelon will be your carotid triangle. You remove 2, 3, 4 in thyroid cancers. So 2, 3, 4 in thyroid cancers and laryngeal cancers. 1 to 4 in oropharyngeal cancers. In parotid tumors, you have to clear 1 to 5. So 5 is most commonest area where carotid in parotid triangle. In parotid tumors.
Thank you, Dr. Kannan. If anybody has got any questions. Info. It's a nice presentation, Dr. Kannan.
Thank you, sir.
We can go on to our,
Thank you, sir.
can start your dissection.
Thank you, sir. It was an excellent feast to watch and learn neck dissection being done in such a beautiful manner. I would now like to call Professor Gopalakrishnan, sir, to felicitate the speaker with a memento. Thank you, sir. I request Assistant Professor Govindarajan, sir, Department of ENT MGMCRI, to felicitate Professor Gopalakrishnan, sir. Thank you, sir. The delegates can start the dissection. And if you require any assistance, please inquire the resource person.
இப்போ அடுத்து ஒரு ஆன்லைன் செஷன்
Tea and snacks are provided on the first floor for the resource persons and the second floor for the delegates. Kindly help yourselves. Thank you.